Hi everyone, it's Dr. BT, and today I'd like to talk to you about reproductive cancers in women's health. First one we want to talk about is ovarian cancer. Ovarian cancer is very insidious. There is no screening. The cost outweighs the benefit. So what we have to do is do a risk assessment, and we have to look for women who have history of familial cancer syndromes. Those would be breast cancer like BRCA1 and 2, pancreatic. If they had a history of breast, colon, or uterine cancer, these women are at very high risk. And then 2 first-degree relatives with ovarian cancer. Of course, smoking damages epithelial tissue, and so women who are smokers tend to have a greater risk as well. So presentation is very nonspecific. So if you look at my little, actually they should look like this, my uterus with my ovaries, they're very nonspecific because the cancer grows here and we don't feel it until it gets really big and starts pressing on other tissues. And so as this it was supposed to be this size, and now the ovary is very big and it's pressing on things. So the reason why they even come in is because they have all that pressure from the enlargement of their ovary. So the most common symptoms are bloating, unusual abdominal or lower back pain or fullness, abdominal pressure, and then lack of energy. They can have some mild GI symptoms, obviously, because this uterus is here, and then, your intestines surround this, and this ovary can enlarge as it grows with cancer and press on the colon. Dyspareunia, painful intercourse, because of, again, this is enlarged, and so anytime any movement is here in the vagina, it can put pressure on that. Abdominal pain, of course, with the growing cancer, bloating, urinary symptoms, simply because it's so close, and again, this is enlarging and growing. Dyspepsia, so they can have some heartburn, abdominal fullness, increasing abdominal girth, so they'll say, my waist is getting bigger, so that's a big one. Cramping, of course, because of the enlargement and pressure. Irregular vaginal bleeding, that could be some METs as well. And it could also be where the cancer has some inflammatory products and it can cause bleeding to go in the tube and then actually come out of the uterus. Fatigue, pelvic pressure, and back pain. Those are all self-explanatory. So physical exam. So by manual exam, you always are going to go in and put your 2 fingers in the vagina, and you're going to sweep these ovaries to see if you feel them. Of course, it is normal for them to be non-palpable, but if we do feel one, we are always of concern if it is larger than an almond. So the times that we always do a bimanual exam is when we have abnormal vaginal bleeding, when we have pain. If there's any type of pain, a bimanual exam is indicated. Lesions, so if there's any new lesions, we need to look and do a bimanual. And then, of course, an abnormal discharge. So that would be a bimanual exam. Abdominal exam for ascites. You guys, this is really late. This is like usually METs. So we know that once they have ascites, we're late in the game. Imaging, we can do a transvaginal ultrasound. Of course, we'll call and order that. And then we can do a CA-125. So a CA-125 is a diagnostic tool that tells us if the ovarian cancer is getting worse or better. So it is not a screening tool. They did try it years ago as a screening tool, and it was just not cost effective, and it's not specific enough for this to screen a whole population. So whenever we do a transvaginal ultrasound and we get back that there is an ovarian solid tumor, then we go ahead and have the CA-125 drawn so that when we send them to the specialist has a baseline as soon as possible. If they're high risk, we refer them. So let me move my little camera here. Of course, anybody who comes back with an ovarian mass, we're going to go ahead and refer them. But if we have the high-risk population, so that is those people with those cancer traits, it's these people right here, familial cancer, breast, colon, or uterine cancer, first-degree relatives with ovarian cancer, are smokers. If we have those people who have a persistent ovarian cyst greater or equal to 5 centimeters for 6 weeks or greater, and their reproductive age, we need to go ahead and refer them, because we may not be getting the full picture just on our ultrasound. So high-risk women need to be evaluated a little bit more differently than if they have an ovarian cyst. We have to evaluate them for cancer. So endometrial cancer, so of course this is the endometrium, and this is the little lining, I'm looking in the camera, the lining of the uterus, and we know that estrogen makes this grow, and we know that progesterone rises, and when progesterone falls, it causes this lining to come off. And that's what prevents this lining from getting too thick, is the rise and fall of progesterone. So some risk factors for endometrial cancer. And endometrial cancer is when this gets too thick and it turns cancerous. That's all that is the endometrial lining. So unopposed estrogen, for whatever reason, in a medical circumstance, we could just have low progesterone and not enough to cycle. So the endometrium gets thicker and thicker and thicker. Prolonged anovulation. So if they're not ovulating, they don't have that big, they don't have the cycle. So they don't have the rise and fall of estrogen and progesterone. So the endometrial lining can just continue to thicken. Oligomenorrhea is little bits, not enough to wipe the whole thing off. Nullipory, never had a baby. Obesity, we know that fat is stored in estrogen. Estrogen is stored in fat. So it makes people who are heavier at higher risk for endometrial cancer. Early menarche and late menopause, that's just a guideline. They had more periods or more time to have a thickened endometrial stripe. Endometrial hyperplasia, which is the thickened endometrial stripe. So on ultrasound, when we actually look at this with an ultrasound, when we measure this, this is called the endometrial stripe, and we see how thick it is, and that tells us what our risks are for endometrial hyperplasia. Hormone replacement with estrogen only. This is never, if you have a uterus, you cannot have estrogen only. You have to have the progesterone so it doesn't get too thick and causes to have endometrial cancer. Smokers, of course, polycystic ovarian syndrome. This is because they never really get that big. They have too much androgen in their ovary. And so they never fully ovulate. So they go for long periods without menses, and so their endometrium can thicken, and can cause them to have hyperplasia. Thusly, they can be at a high risk for endometrial cancer. So we want people to either have a menses every month, or if they're on like a LARC, the high progesterone level prevents them from their endometrium from getting too thick. So you want one or the other. And then tamoxifen therapy for breast cancer. But the 5-year survival rate is 85 to 95% if diagnosed early. So this is why we're need a really good menstrual history. We have to find out what's going on. So if somebody comes in and tells me, no, I'm not having periods, then I say, what kind of contraception are you on? And they say Mirena. Then I'm not worried, because I know they did not grow. I know that they put this IUD in when they were on their menses or soon thereafter. I know that they do not have a thickened endometrium because of the levonorgestrel prevents the endometrium from thickening. So endometrial cancer, 80 80 to 90% they present with abnormal vaginal bleeding as a cardinal sign, but may also present with watery vaginal discharge. But you guys, anybody, especially postmenopausal, if you are postmenopausal and they have bleeding, this is a huge, huge flag for endometrial cancer. But even with your people who are not postmenopausal, if they have this painless, irregular vaginal bleeding, we got to do a speculum exam. We got to see where it's coming from. Is it coming from their cervix? Is it after intercourse? You know, is their cervix inflamed, or is there a spot on their vagina, or is it actually coming from the uterus? So if it's coming from the uterus, we have to really look at this. So symptoms: abnormal vaginal bleeding, pelvic pain and pressure. And then you can see, here's an ultrasound. So sometimes when you do a PAP, you could get back an AGUS, which is atypical glandular cells of undetermined significance, which is a super ominous sign for endometrial cancer. But we do a transvaginal ultrasound too to look at how thick the endometrial stripe is. So down here you can see, here's the myometrium, or the muscle, and then this is the thickness of the endometrium, which is increased. It's very thick. And so whenever you get increased endometrial thickness, that would be a serious high risk for endometrial hyperplasia or endometrial cancer. So we're going to refer to them to the GYN oncology. AGUS, what we just said. Oh, let me take that off. Oh, sorry. Oops. AGUS. So I don't know where the F is there. And then a transvaginal ultrasound if the endometrial stripe is greater than 10 millimeters among postmenopausal women. We're definitely going to refer them for either one of those. Any postmenopausal bleeding merits a referral to gynecology for a further workup. So just remember, if they've stopped their period for greater than 12 months, which would be menopause, and they start having vaginal bleeding, this is a very ominous sign. It's never normal, and you want them to go in. Women older than 35 with risk factors should have a pelvic ultrasound, an endometrial biopsy, or both. And again, this would be all of these people who have had issues or have had estrogen alone. We have to do a good workup on them. And then younger women with vaginal bleeding that are unresponsive to therapies merit an ultrasound, endometrial biopsy, or both. So let's say we did a progesterone challenge. A progesterone challenge is just 10 days before they're supposed to have a cycle. And some people who don't have cycles, we give them the progesterone, and I'll talk about that in another video when I talk about amenorrhea. But we'll try to give them a big bolus of progesterone so that when the progesterone falls, the endometrium will come off. And so that's what we want. We want them to bleed, and then we want to put them on some type of hormone regulation, whether it be pills. We can put them on monthly pills so that they have a menses every month. I'd like to do that for at least 6 months before I even recommend an IUD, to make sure that everything is good. So they should be responsive to this, or they should be responsive to therapy with birth control pills. It's just something that has a rise and fall of progesterone or a rise and fall of estrogen and progesterone. They should have a menses. Sorry about that. All right, so vulvar cancer is just cancer on the outside. So your vulvar is the external portion of your genitalia, the part that we can see. So you guys, it can be anywhere. It can be on the clitoris, on the minora, on the majora, but it's cancer here. A lot of times we can see melanoma here. We can see tumors, solid tumors here, all kinds of stuff. So it's really important when you're inspecting to really look really good. We can also see perineal here. So some symptoms of vulvar cancer: there's really no risk. There's no identifiable risk. There's nothing that can cause vulvar cancer. We know the symptoms. So itchy, they'll say they're itchy, or they have a burning sensation. Dysuria, difficulty urinating, bleeding, pain, and discharge. all of those can be reasons. And of course, with the 4 reasons why we always do a pelvic exam with a bimanual would be abnormal vaginal bleeding, lesions, and this would be an example of a lesion, abnormal discharge, and then pain. So you guys would always want to look. So inspection, we're going to look at the skin, and we're going to look for some changes in pigmentation. Look at the skin, and then we look and see if anything is thickened or reddened. Look for ulcerations, nodules, fissures, or abnormally raised areas. Most do not do we do not do biopsies in clinic. We refer to a gynecologist because we're family nurse practitioners. So if, say for instance, you see, I don't know, a raised area and you're like, let me try some prednisone, let me try a steroid on this, and see on just this one little tiny area, or you're not really sure of what it is, and whatever your dermatologic finding may be, you use that treatment there on that skin, not it has to be skin. And so you put it on, and we hope that it resolves. But if it doesn't resolve, we need to send them out for an evaluation. Dermatology, they can do a biopsy, and we can send them to GYN oncology as well. So if someone's over 60, they're at risk for cancer. So promptly refer them if there's a new lesion, if they're 60 years old or greater. So vaginal cancers are almost always due to endometrial cancer that spread or cervical cancer that spread. But in cases that it is not secondary to endometrial or cervical cancer, we see it in the offspring of women who from 1940s to 1970s took this medication called diethylstilbestrol. And it's also called DES, diethylstilbestrol. So the children, those children of the moms who took diethylstilbestrol, which is a synthetic estrogen that they took to prevent like preterm labor and such, those children have issues with their genital tract. And some of them, no, it's normal. It's a variant of normal sometimes to have, 2 cervix and 1 uterus, or 2 uteruses and 2 cervix. It's just a variant of normal. But these children of the moms who took diethylstilbestrol, they have malformations of the genital tract. And there are 40 times greater likelihood of developing clear cell adenocarcinoma, and it's usually at the vagina and lower tract than women who were not exposed to DES prenatally. So I was born in the 60s, and so I'm 55 years old, so like people who are like 45, they they still have all those risks. So a lot of times we think that people have aged out of this because if they had it let's say someone was pregnant in the 40s, those women now are 82 years old when it first started, but we haven't aged out through the people who were born in the 70s. So looking at their birth date is really important. And then DES daughters, the synthetic estrogen, they have a higher higher risk for breast cancer after 40, pancreatic cancer, and cervical cancers because it was estrogenic, and they were in the process of organogenesis when this teratogen was introduced. Currently, though, I do want to say this, that we still use this drug to treat men with prostate cancer because it is a synthetic estrogen, and it can decrease the rate of which prostate cancer grows. Vaginal cancers, here, I'm going to slide this over so you can see I'll show you my stage 4 in a second. So diagnosis is when we're looking, so again, you have to do a speculum exam and a bimanual with anyone with abnormal vaginal bleeding, unusual discharge, lesions are pain. And so this would be like a lesion. And of course it could have a discharge, and it could be painful as it presses on the nerves as it grows in the vagina. So we need to look and see if we see anything when we're doing our speculum. A clear speculum is great because you can look at the walls. Then of course you're going to refer to a gynecologist. But as you can see on here, pull over my thing, this staging. So you'll have a lesion here in the vagina, and it's found on the vaginal walls. And then the cancer, stage 2, is where it's spread to the tissues. But then, of course, stage 3 is where it goes to the lymph system. And then stage 4 is mets to other organ systems. So vaginal cancers, we have to watch for those. And then, of course, we're going to refer those to a GYN oncologist. Okay, so the USPSTF guidelines say that we need to do cervical cancer screening every 3 years. Age women 21 to 29. For women 30 to 65, we can do every 5 years with the HPV co-test. We do not want to do any pap smears in anyone under 21 years old. It takes about 10 years for cervical cancer to grow outside of the cervix. And so this is why our screening was cut back, because we saw there was more harm than good for doing every year screening because it produced fear. We had far too many procedures on the cervix that were not needed. So if the patient was previously screened and negative, so they've always had normal pap smears, they were negative before, we can repeat the pap smear in a year if they've had atypical cells of undetermined significance. If there's nothing in their history, no issues, previously screened, we're good. Otherwise, you want to go by your American Society of Pathology to look at the screening guidelines, and then, with the pap smear referrals, and I will put that as a link for you. Breast cancer. So the USPSTF assigned a routine screening women age 40 to 49 as C. So that would be in select populations. Moreover, patients who are at high risk, those who are BRCA positive, BRCA1 and 2, or who have had pancreatic cancer, things like that. And then they have a grade B for women. That would be everyone to be screened every other year from age 50 to 74. And thank you very much. I hope you have a good day.